this relationship so important, more important than your stockbroker, right? Because your doctor is going to help you stay healthy and create well-being in your life. Culture-driven, defining, we've talked about that. Grounded in active knowledge, right? What's the foundation for intrinsic motivation? Active knowledge. If I don't know something, I can't get motivated by it. I need to know that Budweiser is the king of beer for me to go order a Budweiser. I need to know that Nike says just do it for me to buy the sweatsuit, because as soon as I put that sweatsuit on, I'm going to go do it and lose 30 pounds, right? That's what we call active knowledge. Active knowledge, in this context of the direct care discussion, is what? Caring requires time and passion, right? But Dr. Blanchard said caring requires time and communication. That's true. But you don't ever get to communication without passion. Honey, I love you. Let's spend some time together. All right? Try to keep a marriage together, not spend any time together. That's not possible. Right? Caring requires time and passion. So, young Kyle, I come in as the doctor, and he's a young man, so he gets 6 minutes in a traditional scenario. I'm a guy that's a little long in the tooth, so I get 8 minutes. And John, who's considerably younger than I, he gets the difference, he gets 7 minutes. That's what I get with the primary care doctor. But that's not love. I want to go see Dr. Blanchard and get some time with him. And guess what? The employer wants me to do that too. Why? Because when I get time with Dr. Blanchard, I get healthier. And the healthier I am, the lower the healthcare costs. The lower the healthcare costs, the healthier I am, the more productive I am at work. The more excited I am about the culture of that employer that invests in not this kind of relationship called the human relationship. Everybody with me now? Okay. So, the foundation of intrinsic motivation, let me make a point here, is that our technology company, which puts all these applications on the phone, anybody work for people like Delphi Motors here? Okay, anybody work for Delphi? No? You'll see it in General Motors. If you get this and you play with this, that's our application to get healthy. All right? So we have to get this knowledge. But the other piece is that we have to do to make sure that we get to this is to make sure that we get people engaged. They got to invest their own time, their own money, and you got to demand individual responsibility and active engagement of the patient themselves. It has to be empowered by the patient-physician relationship, which is what we've really been talking about today. And it must demand that the employer invest strategic assets within the business for this. So I'm going to skip the next slide. Just skip it and go to the next piece. So bringing this together is 4 points in all public policy we have to be engaged with. So I don't care if I'm going to D.C. and I'm meeting with the most knowledgeable person in healthcare in the world. If they don't address these 4 issues, then there's no conversation, there's no solution set. Notice the insurance company's not up there. The insurance company at large has not brought a solution together for us for 70 years of their existence in the equation. They're not the answer. They can be part of a solution, but they're clearly not the answer. The 4 elements of the answer is I want the best quality I can get. Okay? Because quality will always be the lowest cost. For me to get the best quality I can get, I have to have a relationship with somebody who's going to guide me to the right care, at the right time, in the right setting. I need that patient-physician relationship, and direct care brings that to me in the equation. Number 2 is I have to have medical literacy. If I cut my hand cleaning my gutters under the CFO of an organization of 4,000 employees, I'm up on the roof cutting my gutter, what kind of financial thought process do I have? Not good. It's a $9 an hour job. I shouldn't be up there cleaning my roof. But so that's the first thing. But the second thing is I cut my hand. I need to understand that I don't have to go to emergency for that. I need to know how to care for myself. I need to know how to get to my doctor and be engaged. The third thing is the underpayment of primary care. I'm here to tell you, and Tom talked about this, it's actually 6%, close enough, 5%, close to 6%, is what gets consumed by the primary care physician. That's it, today, all right? The primary care doctor is underpaid. If you go to a good primary care doctor who cares about his patients, he looks haggard, she looks haggard. They are exhausted people, okay? We need a change in that process, and direct care, again, gives us that opportunity. The employer can participate in this process. And of course, we're designing plans in the marketplace today that would allow direct care to participate with the employer and with the patient. And the last piece is that we need to understand that reward, the employer-employee relationship, is moving away from cash reward. It's moving to well-being. And we're truly in the health age again. Right? When my wife goes to the supermarket, she does not buy food. She makes a healthcare investment in the family. Right? And that's what's happening in all that we're doing in the culture. What direct care offers you the opportunity to do, and it's intelligent, is to have a human relationship with someone who's going to care for you. Right? Does that come with a cost? Absolutely. Can we mitigate that cost? Absolutely. Does that cost and that investment result in improved quality of care? Absolutely. Does that lower the cost of health care in total? Yes, it does. Right? And that's what this whole conversation is about, as simple as I kind of try to make it and move forward. Now, I say all of that, and I work every day in one of the most complex environments anybody can imagine. Right? Because there's tremendous inertia in the healthcare space. That pharmacy that's turning over 400% on their drugs, do you think they want to lose that? They don't want to lose that. They want to keep that. Right? So going back to the leadership thing, you all leaders help us lead in the right direction.
Thank you very much, David. Last but not least, we're going to introduce Dr. Rob Steele. Before I do that, if you guys, after this presentation, we're going to be getting questions from the audience. So if you guys can start thinking about what you'd like to ask, and if you could, when we get into the Q&A forum, we're going to ask you to come up to the podium to ask your question, so we can just kind of get up in a line there, if that's okay, all right? So without further ado, I'd like to introduce Dr. Rob Steele.
Thank you. Thanks, Senator Colbeck, for putting this on. The slides you showed at the beginning were very insightful and very complex as regards to understanding of this. And the ally that we have in the state of Michigan with Senator Colbeck is really quite unusual, and we thank him for all the hard work that he's done on that. I just want to comment real quickly on what's going on with bureaucracy in medicine, and everything that's been talked about with direct patient care is to try to get away from the bureaucracy. I see you stand on a couple of physicians out here, but the bureaucracy is everywhere the physician turns, and our last speaker mentioned this idea of the CFO out there doing a $9 an hour job, and I can't tell you, it's impossible for me to convey to you what's happened over my 30-year career in medicine, and how much time I now spend doing things that used to be done by somebody who basically had a high school, education. I probably spend about 50% of my time doing things that were now in the past done by people with a high school education. And it's really astounding, and of course it's in part of the rationing that's going on, that has to go on with all the money that's been diverted away from patient care and put into the administration and the bureaucracy. So, this bureaucracy happens in a lot of ways. ICD-10 is one that's coming up here now for physicians, and this is a big coding scenario where you have to do a 7-digit code for all the diagnoses and everything that you see in the patient. Are there any musicians out there? If you're a musician and you get hurt playing the piano, don't worry, we got an ICD code for that. But don't worry, if you play the drums, we got a separate code for that. Or if you play the woodwinds, you got a code for that. If you play brass instruments, we got a code for that. We got a code for if you're injured by a burning water ski. We got a code for someone who gets assaulted by tap water. And perhaps most appropriately, there's a code for being injured by a civilian drone strike, but let me not comment further on that. But this whole ICD thing, the whole reason this bureaucracy invented is strictly because of the third-party system of payment that everybody up here is speaking about and trying to get away from. So that when you see your physician, it would be no different than going to the grocery store, no different than having a plumber come to your house or whatever. It's a transaction and a relationship between you and them without a third party involved. And all of this bureaucracy is to take care of the third party. And in fact, they're very clear on it in this ICD-10 thing being so complicated. They will even say, the people who are paying want to know what's going on, and they don't want the cliff notes, they want a novel. And this is for the physician to do, the person who's been to medical school. And so they talk about the average compliance cost for ICD being anywhere from $50,000 to $200,000 for a healthcare practice. So, you know, I won't say anything else about that, but it's just really crazy. I mean, everybody always, when I was growing up, everybody said, hey, I want my kids to go into medicine. And they would say, yeah, man, my son's going to be a doctor. Have your kids go into ICD-10 coding, and they'll do way better. The only other thing I wanted to cover real quickly is the idea of CON, or Certificate of Need. And this is the wall. This is the great wall that prevents true consumer ability to compete on cost in the healthcare system. You know, Matt mentioned our friend Keith Smith out in Oklahoma. You should look up on YouTube, Keith Smith, Oklahoma, Surgery Center of Oklahoma, and watch that little short YouTube. But CON laws were originally designed to control cost, and that's because, of course, the people writing these laws felt like all of those smart people we've heard of, like Jonathan Gruber, saying, we're smarter than you. You're not smart enough to be a consumer when it comes to healthcare.
Just a point of order, maybe explain what certificate of need is.
Yeah,
A lot of people don't know.
so certificate of need is this idea that if someone wants to open a new hospital, set up a new CT scanner, provide a new medical service, they have to go to the government to be approved to offer that service. And it was so bad actually for a while, in 1974 under the Nixon administration, actually it was mandated that every state had to have one, and 49 went on to implement it. That's since been repealed. In fact, you know, there's about 36 states that still do it. But you would think, like any bureaucracy, and I love Senator Colbeck's comment that it's about control, not care. The bureaucracy wants control. They don't care if it's been proven or not. There has never been a study that showed CON laws controlled costs. There have been CON studies that showed it made profits higher for hospitals, reduced access for patients, and limited care. And so if someone wants to go and offer a new hospital, like in Oklahoma, where our friend Keith Smith has a surgery center that offers procedures for about 15 to 20% of the cost of your local hospital down the street, that is actually against the law in most states. And in most states, when you go to try to ask to provide this service, who's sitting on the board? But representatives from the American Hospital Association. Somebody had mentioned how powerful they are in the state of Michigan, but I am happy to say that you will see a push here in Michigan in this legislative session to get rid of the CON laws, and it will be interesting to see how that goes, because if you thought freedom of work was big, getting rid of the CON laws will be every bit as big of a bloodbath when it comes to third party, because if you're in the hospital and you don't want to have to compete with someone who you know can do a better job, you're going to do everything to keep that one slide that said, why would you want to cut your revenue in half? Right, and so that's what's going on, and so everything is about bureaucracy, and it doesn't make any difference whether it's HIPAA, when you go in and sign your HIPAA form with your doctor, which creates a whole set of bureaucracy where there's a bunch of people in the back room. It doesn't make any difference if it's now another third-party group doing board specialty certifications, which gets the doctors off doing a whole other set of things that has nothing to do with patient care. It doesn't make any difference if it's the electronic health record. And I have a daughter who lives out in California who's, you know, kind of college age, and I just got my letter from Anthem. The breach of the health care, you know, 60 million people, data out into the internet. And so when you think about a bureaucracy, when we have a government who has a national security advisor walking out with the most secure documents in the world stuffed in their pants and in their socks, and you think that the government bureaucracy is going to protect your health information, what everybody's been talking about with direct patient care, the key thing here is you need to look, and we need to help you find a position where you can go in where they are not a HIPAA-covered entity, where they may not even use an electronic record, where they don't go through all these crazy certifications over and over and over, where their attention is on you. We are dealing with a bureaucracy who states that the Hippocratic Oath is an impediment to what needs to be done to improve the healthcare delivery in the United States. And of course, anybody who has any general knowledge of the Hippocratic Oath, it means that you do no harm, and that it's the doctor-patient relationship that is supreme. And of course, someone else mentioned about all the social population control that, you know, we're learning about. The MCATs, for the first time coming up, the MCATs are going to have a huge section that has nothing to do with whether your prospective student being selected to go into medical school is good at biology, chemistry, math, and science, and these sorts of things. They are going to have all kinds of sections now in MCAT that have to do with whether or not your future doctor, who's going to be selected based on MCAS, has the right view of taking care of a population in the government's role in that. So doctors are going to be quitting in droves or moving to this other system. I mean, I had just the other day, a plumber came to my house and they were doing all this work, and I said, my God, I said, that's more money than I get paid as an interventional cardiologist. I'm a plumber, a human plumber. And I said, man, I can't believe that. I said, that's more than I make as an interventional cardiologist. And the plumber said, yeah, it's more than I made as an interventional cardiologist, too. Let's again thank Pat and his wife, Senator Colbeck, and his wife, Angie, for everything they've done. Senator Colbeck left a secure job with good pay. You can tell he's an engineer, and his wife's a physician, and they have put it out there on the line for us to have the opportunity to help improve the future of the state of Michigan for our kids and our grandkids by facilitating some of these things. So once again, thank you, Senator Colbeck.
Thank you very much, Rob. Thank you very much for all the panelists. Hopefully you see there's this kind of common theme here. We're in a little bit of a battle right now. We're in a battle between folks that think they know better about how to run our lives and how to run our medical practices, how to run our businesses, and those who figure out that they can actually go off and they should have the freedom in a free society to go off and make those decisions on their own. And I think here, Tom's pyramid graph is kind of a good way of looking at this, if you will, or pyramid diagram here. There are folks that truly do want to do a lot of top-down management of our individual lives, and then there's folks that are trailblazers, like what's going on with Dr. Blanchard in his practice, where we're actually just refocusing the delivery of medicine on that patient and doctor relationship. So there's a little bit of an opportunity that we have here in the state of Michigan. If we go to run one route, we're going to be going down and seeing the higher costs associated with those out-of-control administrative graphs relative to the patient care on it. The other route, however, leads to an opportunity where Michigan can be a trailblazer in the healthcare system, in our free market healthcare system in the entire country. And imagine what the impact of having a healthcare system in the state of Michigan that costs 20% less than our competitor states all around us, that actually delivers better health care for all of our residents. What do you think that would do from the perspective of jobs here in the state of Michigan? What do you think? I mean, people talk about competitive labor force all the time. That's why a lot of people talk about our jobs going overseas because we can't afford the labor. Well, we just found a way to take 20% of that cost out of each individual employee here in the state of Michigan. That's over $35 billion savings across the industry here in the state of Michigan. What do you think that would do for jobs and keeping our kids when they graduate from schools back here in Michigan? And what do you think it would do if we were to deploy these types of methods here in context of Medicaid, where you can cut $7 billion of our state's $53.1 billion budget? What do you think that would do to the pocketbooks of our taxpayers? What do you think? How much money do you think that would put into roads? How much money do you think that would put into our schools? We need to start thinking differently about this. We need to make that fundamental choice about freedom in our healthcare system and reject this paternalistic push that's going on right now towards more and more control out of your life. So with that being said here, I want, first of all, before I forget, the presentations that we got for tonight are part of some of them I haven't had a chance to ask yet, but if there's, we're going to try to have all these presentations posted up on the online. And Penny, who's my district manager, raise your hand, Penny. She's the one who helped keep us all organized here and get ready for tonight. So thank you, Penny, for all your hard work on this. She's going to help us put this thing online as well. There's online tapings of previous forums that we've had as well, and Tom and Matt and Ron have been up there as well before in the past, and that's available online. So all this information, we're trying to make it so that we can share it with you. And just like Dave was talking about, each and every one of you guys are leaders here. The intent is that for you to be able to help share this with other people. So with that being said, I really want to hear what you have to say about what you've heard tonight, and maybe some questions that you came in with before you came here. And, oh, actually, before I get into that, how many of you, is this the first time you've ever heard of this supply side economic constraint called certificate of need? How many of you thought we had a free market healthcare system already before the Affordable Care Act? Okay, good. All right. Okay. All right. Well, obviously, CON's been around for how many years now?
Well, the first CON was 1964 in New York. It was 10 by 1974. The Affordable Care Act actually outlawed physician-owned hospitals and their ability to do business under the Affordable Care Act. And of course, the paradox is that when Medicare made their first rankings after the new Affordable Care Act law came out, they ranked, physicians and gave them, or ranked hospitals and gave them payments or quality. The top 10 hospitals ranked by Medicare, 9 of them were physician-owned, and that was outlawed.
All right, so giving you a lot of stuff to consider here, a lot of stuff to mull about. I'm just curious, will the first contestant please step up to the podium here? So anybody have any questions that you'd like to follow up on?
I just wanted to know, after you guys have laid all this out for us, and being the layman that I am, and running a small business, I'm looking at this, and I'm asking myself for the legal part of this, dealing with the IRS and all their shenanigans, and how complicated they made this on me. These are different little parts here, and for a guy like me to put this together and not end up owing a bunch of money I don't have, or even getting myself caught up in a bunch of paperwork or whatever with them. Is there anything that you guys collectively have put together to try to give us something that we can, arrows and, diagrams, something where we know where we're going with this? Because I would love to pull myself out of that system the best I can and, put these different pieces together. And, of course, the other factor was the cost value. You're saying that, if you have if you got your primary doctor, you're doing that out of pocket, and then you're going to go buy a catastrophic policy, you put that together, is that going to be cheaper? And how do I figure that out without sitting down for weeks trying to get somebody on the phone to tell me what the heck's going on?
Tom, I think he's looking for your easy button.
I saw one of those diagrams that said push it, and
In healthcare, there's no easy answers.
I understand that, but I was wondering.
So the question is, we have to know a lot about you, how many employees you have, where they're located. The answer is that can be done. We can develop a contract that allows for direct care access, right? But, as the owner of the business, you have the responsibility of making sure it's a sound financial conclusion to what you're doing from a design perspective.
I guess at this point for me, I'm looking at it and saying to myself, is this worth my effort to try to start going down this road?
It is. So let me just give you an example. So at 100 employees,
I have 3.
Okay. Well, at 3 employees, you have a very limited set of answers. Okay. You have a very limited set of answers that are available.
Yeah.
Right. So I'd be happy to talk offline.
And part of, what I kind of scooted through real quick on the slides early on, we're talking about that patient-centered care solution. What we could do from the state, state level, is concept of these private exchanges, that aren't run by a bunch of government appointees that determine what list could, or what plans pop up in your search engine results, which is susceptible to all kinds of chicanery from my perspective. But that's one of the areas. And the concept of an exchange and having a one-stop shopping center, I don't care if that exchange is BlueCrossBlueShield.com or David Wilson Partners or Forthright Health or whatever the case may be. The concept of a one-stop shopping center, I think, is where you're looking for it, right?
Well, that was not really. What I was really looking at is I'm asking myself, it's kind of convoluted, all this stuff.
Yeah.
And when I look at it just without seeing that chart, that's what my brain sees, just in my small world.
Yeah.
I'm just trying to manage just my family's healthcare, you know? And, you know, you talk to different entities, they give you all different answers, and you're going, so what's the right?
Well,
And then at the end of the day, we get the bill, and it's still huge, so, you know, we're trying to figure it out.
well, one of the things around direct primary care, once you're aligned with the direct primary care physician, the spaghetti diagram disappears. You're just focused on, I got an appointment to go see a doctor that's agreed to provide X number of services for X dollars per month. And so this gets
Is there a
simplified.
list of those already that are available?
That's what we're just starting out here. That's what we're, it's
That's
a
what
big
we're
enough.
figuring out. Okay, so that's where the infancy stages of all.
We are, you guys are officially in early adopter stage around this. I mean, frankly, this is the stuff that, this is the way medicine used to be practiced, 60 years ago. So it's sad that this is early adoption phase now again, after actually having a pretty good model back then. It's kind of back in the 60s when the government got involved on this that things started going south. So we're trying to hit the reset button and say, hey, government, you're just not doing so well.
I'll be paying attention, and I really appreciate all of your efforts, because this is really, I really like this.
Thanks.
Thanks.
Just to follow up on that, I think the one thing, if you can do now with 3 employees, I don't know, you could speak to that, about whether he could get into a high deductible plan where your people are shopping for healthcare, because that's going to put pressure on everybody, the market too, and we have to respond as suppliers of healthcare to more people shopping for care. That'll be a great step. I can tell you in my group, we've got about 300 employees, and with the docs, and we save about 40% on our premiums just by going to a high deductible health plan with health savings accounts. That's why the market's going that way.
And health savings accounts are available in Michigan now, right?
Yes.
You can do that legally?
Oh, yeah, I have it through the state right now.
Thanks.
My name is Bob Cushman. I live here in Northville, and I've got 2 questions. I believe in the concept. It sounds good. I don't have the knowledge that you all have when it comes to defending it. And one of the areas that I don't feel qualified to talk to is Medicaid patients. People from both sides of the fence, left and right, are concerned with how, if we were to replace what we have now with this, how specifically do the services of Medicaid patients get paid for, and are there any holes in that?
Yeah, right now, just, Medicaid is actually offered out on a competitive bid to a suite of managed care providers, and they all kind of rotate through the system, and it's essentially an HMO. So it's, while you can't say that it's completely the spaghetti diagram from a government perspective, but you get the same types of controls in place from an insurance perspective for the group that wins the managed care contract for this. So essentially, you've got controls that regulate or ration the care that an enrollee sees, that if you flipped it around and actually put in this direct primary care model instead of that, well, now you got them focused on the prevention rather than of their needs. You've got more time with the doctor. The way I like to say it is, right now you get a My Child card or whatever that you carry forward into a doctor's office. Under Medicaid right now, I think you get reimbursed 49 cents on the dollar. I think was the last figure that I saw for your procedures that are out there. So doctors are encouraged to enforce the private industry equivalent of the spaghetti diagram to ration the care, drag out the time between visits. Under direct primary care model, that's not the case. There is no more scarlet letter for that Medicaid enrollee anymore. They don't have the My Child card. All they have is an account that says, I get to go see this doctor in accordance with this retainer agreement for my direct primary care services as much as I need to. And they get the care that they need, and they don't go into the hospital as much.
For someone that's under that poverty level, is it 100% paid for by the state?
That's the push. There's a couple
Would
different models.
it be 100% paid
Yeah,
for by the state?
According to the
primary care?
According to the plan that I outlined with Senate Bill 459 and 460 at the time of our discussions of Medicaid expansion back in 2013, that was indeed the plan. So it's essentially saying, federal government, please authorize us to deliver health plans in accordance with this direct primary care plan. We need a mother may I to allow that they would allow us to practice this model as part of our Medicaid support. And so we would have changed all of our enrollees from a managed care plan to a direct primary care plus high deductible health plan under the plan that I put forward. That was not the plan that was adopted. We went with the managed care plan instead. And just for cost references, that managed care plan for single adult costs about $5,000 per year for that plan. Under the model that I had rolled out, it was around $2,100 per year with better care. So that's what we gave up in that Medicaid